I'm one of the neurosurgeons here at Lenox Hill. This is being brought to you by the Journal of Neuro-Oncology and Lenox Hill Neurosurgery. And today we have a very special guest, Dr. Rodney Wegner from the Allegheny Health Network is with us to discuss a recent paper published in the Journal of Neuro-Oncology. I'm with us as usual. Gautam Mehta's here. It looks like Jason's a little bit behind, but he'll be here soon. And I mean, we might as well just jump right into it. Actually, John Boockvar is with us today too, which is fantastic. So.
Awesome. Well,
Dr.
thanks
Wegner.
for having me. I was pleasantly surprised to get the invitation to come on here and excited to share our paper with you guys.
No, I appreciate it. So I'll give you a little background on what we're doing, but basically we give authors the opportunity to discuss, the reasons, the results, and the relevance of the papers they recently published, obviously focused on brain and spine tumor disease and neuro-oncology. But we appreciate your time. So why don't we dive right in?
Sure. So just background on me, I'm a radiation oncologist here in Pittsburgh, Allegheny Health Network, and I do a lot of gamma knife radiosurgery, so that's kind of my clinical background. So the background for this study, melanoma accounts for probably 10% thereabouts of patients with brain metastases. It's one of the most common malignancies to metastasize to the brain, along with lung and breast cancer. Traditionally, brain mets have been treated with surgery plus or minus radiation, whether it was radiosurgery or whole brain radiation. If you look at older studies dating back to the 90s and early 2000s, overall survival is pretty abysmal in the 4 to 6 month range. In the past 8 to 10 years, immunotherapy and targeted therapy has emerged in terms of treatment options for patients with stage 4 melanoma, and it does have some CNS penetration and has improved overall outcomes in this patient population, closer to a year, or maybe even 18 months in well-selected patients. A little bit more background. I think all of us know that in terms of local control of radiosurgery for melanoma brain mets, we can expect outcomes in the 80 to 90% range, and that certainly is based on data dating back to the 90s with gamma knife. Looking at BRAF MEK inhibitors and immunotherapy, which both have CNS penetration, there's some prospective data, certainly small series, but that show that response rates in the 55 to 60% range for untreated brain mets, so no radiotherapy in those patients. So the next question naturally becomes when and should we omit radiation for these patients? And some of the more recent guidelines say perhaps for small asymptomatic, I would say numerous brain mets, patients that definitely need whole brain radiation, or patients who have asymptomatic brain mets and significant extracranial disease burden where obviously they need systemic therapy, otherwise they may end up passing away. So the way we went about trying to answer or provide some data to answer this question was through the use of the National Cancer Database. So we examined patients who had brain mets from melanoma, all of who had immunotherapy, and then we created 2 cohorts, one that had radiotherapy to the brain and one that did not. And then we wanted to look at difference in outcomes. Just a couple of slides on the NCDB in case people aren't aware of what it is. It's a large national cancer registry, which is managed by the American College of Surgeons and the Commission on Cancer. It covers over 1,500 cancer centers in the United States. It's important to note that it collects only upfront diagnostic and treatment information on these patients with newly diagnosed malignancies. It has a whole slew of information on socioeconomic data points, so location of the patient, what type of facility they're treated in, whether it's an academic center or a community center, what type of insurance they have. They are able to estimate educational level by percent of patients in that zip code without a high school diploma. Similarly, they can do income assessments based on their zip code. There's a large amount of treatment and staging data as well. It's obviously TNM staging, both clinical and pathologic. They do have primary disease site surgery for most disease sites. Interestingly, for brain mets, obviously there is then not any kind of surgical data, which is a limitation. The radiation is really well documented in the NCDB. They have the type of radiation, the technique, what target or anatomic site was treated, the dose and number of fractions. They also have days to start irradiation. They also have information on immunotherapy and chemotherapy. It's essentially, though, just a yes or no column for that data point. So it doesn't tell you what immunotherapy was given, how many cycles were given, or anything of that nature, unfortunately. Back in 2010, the NCDB started documenting patients who had metastatic disease at diagnosis, and they have codes for lung mets, liver mets, brain and bone mets. The only outcome in the NCDB, again, a pretty big limitation, is overall survival. So we have no toxicity data, no local failure, no distant failure, and unfortunately no salvage therapy data. So what we did is we looked at the melanoma database, which actually went back to 2004. But as I said, they didn't start documenting brain mets until 2010, so that already knocked off a big chunk of patients for this study. They all had to be treated with immunotherapy with or without brain-directed radiation. The stats program I use is MedCalc, and we did a multivariable logistic regression to identify predictors of immunotherapy treatment alone compared to immunotherapy with radiation. We also did a multivariable Cox regression to look for predictors of survival. And then we did this propensity score propensity match, which is kind of popular with these NCDB analyses. And for those, when you do the logistic regression, it can actually generate a propensity score, so a score that indicates likelihood of immunotherapy treatment alone. We then do a case control matching on an exact match on the propensity score, and then run a Kaplan-Meier analysis on that matched set of patients. So the entire data set is really big, which is one of the strengths of the NCDB. So the data set going back to 2004 is over 500,000 patients. But given the time constraints and the fact that it didn't start documenting until 2010, it quickly cut it down to 3,000 patients, and we removed patients who did not have brain radiation or brain radiation without immunotherapy. And then we also used a cutoff of at least 1 month of follow-up to account for a moral time bias. So we ended up with just shy of 700 patients, and most of them were treated with brain radiation and immunotherapy, and 142 patients were treated with immunotherapy alone. Most of the patients were male. The median age was 62, but did span the ages of 20 to 90. Almost everybody was Caucasian. There was a relatively even split of government insurance and private insurance. Almost 2/3 of patients were treated at academic centers. Vast majority had extracranial metastatic disease. So the way we calculated that was if a patient had brain mets and, for example, lung mets or liver mets coded for, we counted that as extracranial metastatic disease. Most patients did not receive traditional chemotherapy. In terms of the breakdown of patients receiving brain radiotherapy, it was a relatively even split between whole brain radiation and radiosurgery. Median follow-up was 10 months for the entire cohort. In terms of radiation, pretty standard dosing for a whole brain radiation, 30 gray, 10 fractions was the median, and for radiosurgery was 22 gray in a single fraction, which is pretty standard based off the old RTOG guidelines. And time to radiation was just over a month, and time to immunotherapy was closer to 3 months. The only predictor on a multivariable logistic regression of treatment with immunotherapy alone was a comorbidity score of 0, which is better performing patients. Score 2 was not
Rodney,
significant, which is, sure.
Rodney, do you think that's just due to the side effect profile of the immunotherapy? I found that interesting.
Yeah, it was interesting too that nothing else really kind of played out. I'm not sure it's related to that. Because this comorbidity score is pretty kind of rough around the edges. It's like literally if patients have coronary heart disease and diabetes and hypertension and things like that. So it's pretty general. It's not very specific.
Yeah.
And a lot of those things wouldn't preclude immunotherapy.
Yeah, sure. Sorry to interrupt.
Yeah, and no problem. I mean, the other thing along those lines is you would think that maybe the younger patients or older patients maybe would be treated with immunotherapy alone or radiation alone, et cetera, you know.
Yeah.
And that didn't play out in the stats. In terms of predictors for survival, no surprises here. Patients who had extracranial mets had a higher risk of death, hazard ratio 1.77. And then interestingly, patients who were treated at academic centers were less likely to die from disease compared to those not treated there. And of course, that might be a surrogate for better performers, people with more resources, access to clinical trials, things like that. And obviously then the combination immunotherapy, radiotherapy, there was no difference in survival compared to immunotherapy alone. So we did the propensity match. And if you recall, there were 142 patients who got immunotherapy alone. So we were able to generate 141 matched pairs, ran the Kaplan-Meier analysis, and essentially the median survival was 11 months, regardless of treatment. So we thought it would be interesting then to break it down and look at patients who had radiosurgery and immunotherapy, and then separately do whole brain radiotherapy and immunotherapy. And looking at the radiosurgery cohort, those patients had a median survival of 19 months compared to about a year for immunotherapy alone, and that was statistically significant. And then looking at whole brain radiotherapy, kind of flipped the curves, and patients treated with whole brain radiotherapy and immunotherapy had a worse survival compared to immunotherapy alone, also statistically significant. So what we concluded from the study was that it might be reasonable to omit brain radiation in certain patients, so small, numerous, asymptomatic mets, which would require whole brain radiotherapy. And obviously, as we mentioned, extensive extracranial disease, which would require urgent systemic therapy. Based on our subset analysis, radiosurgery and immunotherapy appears to possibly improve outcomes. Again, accounting for some of our obvious selection bias, those patients probably have limited lesions, are getting better radiation, probably have a better performance status. And then the limitations, which are pretty much standard across most national cancer database reviews, number and volume of lesions in the brain is not recorded, which obviously would affect the choice of whole brain radiation versus radiosurgery, whether patients had symptomatic disease or asymptomatic disease. We have no idea which patients had any kind of neurosurgical intervention, if at all. We don't know the type of immunotherapy that we use, number of cycles. And obviously salvage therapy would be important, because if somebody got immunotherapy and then progressed and got whole brain or radiosurgery, it would be good to know that and see if that affected outcome. And then toxicity as well, because sometimes these immunotherapies do have significant toxicity. The other thing, all of these patients had brain mets at diagnosis, which is not what we see in clinic all the time. A lot of patients with melanoma will start out stage 2 or 3 and then progress to brain mets maybe 12 to 18 months later. So cannot necessarily extrapolate these results to that population either. And then NCDB does not document BRAF status or PD-L1 status. Thanks.
No, that's great, Rodney. Thanks so much for joining us and presenting this fantastic work. This obviously brings to mind a bunch of questions. This is obviously a controversial kind of subject, and people have gone back and forth on the role of radiosurgery and whole brain for use in melanoma, and especially melanoma metastases. I guess the big question for me is at this point, stereotactic radiosurgery is showing significant improvements. And so, why not include stereotactic radiosurgery in basically every case, especially as the numbers, as the studies keep coming out that suggest we can increase the numbers of lesions targeted?
I agree, Honor, with Spence 100%, especially I think there's some emerging basic science data too that says if you do higher than normal dose radiation like radiosurgery prior to immunotherapy, it might actually prime the immune system and improve outcomes. So it would be kind of interesting to look at it, maybe time from radiosurgery to immunotherapy and see if there's any kind of interval that corresponds with the outcomes.
Yeah. Well, also, now that you mention it, can we find a happy medium on dose? Do we need to go so high, or is there a synergistic effect where you can lower the dose and maybe not get as much radiation necrosis, or kind of limit the effects of that?
That's a really good question. Yeah.
I guess at this point, and you may have mentioned it, but just because, this is kind of an informal discussion and we have patients listening as well, what do you consider now an indication to continue whole brain?
Our institutional practice here is if somebody has 10 or more brain mets up front and does not receive whole brain radiotherapy before. Of course, you can always make, I think, the argument for melanoma that it's probably not going to respond to 30 gray and 10 fractions no matter what's there. So our practice is to maybe do whole brain up front, hippocampal sparing if we can, if insurance will allow it, throw in Namenda as well if the insurance will allow it, and then maybe do a short interval MRI at 4 to 6 weeks. And if there's anything that's still kind of festering there, boost that with the radiosurgery.
So you guys are still using it pretty frequently then?
Yeah, yeah.
So on the flip side, so you talked about kind of the follow-up and observation period for if you just do the whole brain, but with immunotherapy alone, there's going to be a fair number that progress afterwards, after treatment. I think even in kind of the carefully selected groups like the Taube paper in New England Journal where they had combinatorial checkpoint inhibitors, still objective response rates were like in the mid 50s.
Yeah.
And we had looked at the outcomes of adoptive cell transfer immunotherapy for brain mets at the NCI and found that the untreated or previously untreated lesion prior to immunotherapy was the site of first initial progression after immunotherapy in 61% of patients. So these untreated, primarily untreated lesions are probably very likely to progress. Do you guys have, if you do immunotherapy alone and these patients progress, would the next step be whole brain radiotherapy? Is there a follow-up period for those as well?
I mean, for us, we've just been using a relatively arbitrary cutoff of 10, regardless of histology. So if somebody had like 15 to 20 brain mets, got immunotherapy up front, and unfortunately progressed, we would proceed with whole brain radiotherapy first. And I've seen that happen like twice, probably in the past 6 months.
Yeah.
But
How does this?
Oh, go ahead.
Go ahead, Gautam. Sorry.
No problem. But regardless, I think this is kind of the holy grail of where we want to get to if we can avoid whole brain radiotherapy. It's been very effective for targeted therapy for lung cancers, and kind of moving away from whole brain therapy as a first line. And so I think this is very provocative, or your paper is very provocative, but I think it's provocative in a good way.
Yeah, I was going to say, I think you've done a marvelous job with the paper and able to draw some conclusions in a way that I think would have been much more challenging to do, and even potentially problematic to approve patients to an RCT in the current environment, with equipoise and other sorts of things now causing patients to really begin to question whether or not they want to have whole brain radiation therapy, especially if they've got small numbers of metastatic tumors, mildly symptomatic or asymptomatic, and they've got immune checkpoint inhibitors, they've got radiosurgery as options. But I want to highlight, there was a paper that we published in Journal of Neuro-Oncology not that long ago that did talk a little bit about the upregulation of genes associated with radiosurgery that could lead to an apoptotic cascade that would then potentially be leveraged by systemic therapies, including targeted therapies and immune checkpoint inhibitors. So I do think that there are some options for patients where you can really leverage the radiosurgery with the immune checkpoint inhibitors. I'm wondering what your institutional your relative institutional experiences are amongst the panelists about when to give immune checkpoint inhibitors in relationship to the timing of radiosurgery. Do you give them before, do you give them concurrently, or do you give them after radiosurgery in patients with metastatic melanoma?
I think we've at least anecdotally been trying to do it afterwards if we can see the patients before they start the immunotherapy, just based on that emerging data that you mentioned.
And that's what we've been doing too, in short order. I don't think that one wants to wait too long, but we prefer to give the radiosurgery before the immunotherapy. If they've been on it before and they've progressed, then we'll keep it going. We may obviously change things up or add dual immunotherapy over a single modality approach.
Jason, welcome, by the way. I know you missed the beginning part of this, but good to have you on board. What about your practice? I know you do a lot of radiosurgery. Are you doing radiosurgery pretty much up front, or is there anyone in your practice just doing immunotherapy?
No, there are some patients where we will consider doing immunotherapy, but to Gautam's point, I think that the data suggests a response rate of probably around mid-50s at the 6-month time point. And as you know, certain patients with favorable mutations, BRAF mutations, are going to exceed that 6-month median survival. And I think in your study, you showed some appreciable long-term survivors in the patients that were treated with SRS and immune checkpoint inhibitors, so that many of those patients would not be well controlled with immunotherapy alone. It's always difficult to predict, though, who the long-term survivors will be. And so I would say that if patients are just receiving immune checkpoint inhibitors in general, they're going to be patients who have limited numbers of a smaller number, smaller overall volume, and really maybe asymptomatic, and that we'll be following those patients closely, and if the signs of progression, we'll go ahead and treat them. But we also have a low threshold to treat, and we have a multidisciplinary brain metastasis board that meets every Friday, so we can discuss cases at least once a week, if not more often, and those sorts of patients where we may hold back on radiosurgery are going to have be brought back to a multidisciplinary discussion in short order if they show signs of progression.
Yeah. So,
Randy, I have a question.
Yeah, go ahead.
For Jason and Rodney. In some of our glioblastoma patients, we augment when we decide if it's a hypermutable tumor or they're PD-L1 positive, which is extremely rare. We have them get tetanus toxoid immunoadjuvant injections monthly, almost to stir up an abscopal effect. Do you know, are you guys using immunoadjuvants like that? Do you send your patients ever when they're on immunotherapy to heighten the abscopal effect with something as simple as getting a tetanus toxoid every month?
I have not seen that in our practice here in Pittsburgh, at least.
We're not doing that as a matter of routine, but I would say that I can understand the rationale behind it, and I think that there have been a number of studies that have pointed to the importance of the immune response, both in metastatic melanoma as well as in primary brain tumors, specifically glioblastoma. So that I think that there's little harm in doing what you're doing, and probably a reasonable chance of benefiting these patients. But obviously, more study needs to be done.
Right. I think the vaccine patients or the melanoma patients that have 125 mutations, they're very, very high mutation burden. Just something to consider, because otherwise, the immunotherapy agent just may not take hold. And I love the idea of radiosurgery to harness that abscopal effect and to augment it. But it's just a thought that we have in treating some of these. It sure is harmless.
Yeah. So Rodney, just to keep going, I guess, how does this change your practice? Have you guys made efforts to move to different treatment paradigms based on the results of this paper? Or are you looking for further evidence?
I think this is just kind of more hypothesis generating, at least for our practice at this time. And the medical oncologists that see most of the melanoma are still kind of pushing ahead with trying to give more immunotherapy up front. I mean, most of the patients do get discussed prospectively, though. So if I'm at the tumor board or my partner's there, we can try to make a case to get these patients treated aggressively up front with radiosurgery.
Mm-hmm. Great. Well, I think it's fantastic. As always, this is open to questions from viewers as well, if anyone has anything. Otherwise, we like to keep these limited to about 30 minutes. It keeps people interested. It keeps everyone fresh. And, we really appreciate your time. Fantastic work. Thanks again to Gautam and Jason and John Boockvar for coming along for the ride. And this will be posted on our YouTube page probably by tomorrow or the next day. So anyone who missed it, you guys can, pass it around and let people see. The only other thing I wanted to plug this week is that we are hosting a summer seminar series for students called Brain Turns here at Lenox Hill. It's a virtual seminar. So if you guys want to pass it along to any students, or it's really high school and above, high school, college, medical students. And it's about 8 weeks, so about 3 hours a day of, a diverse curriculum in medicine, really ranging from everything from, the administrative staff to advanced care practitioners to neurosurgery. Obviously, there's a heavy neurosurgery slant. But it's looking like it's going to be a fantastic program. And so I just wanted to plug that. The link will be in my bio on Instagram and Twitter and Facebook, probably by the end of today, and it'll stay there for about a week. Next week, we'll be back, same place, same time, and hopefully another great discussion. So thanks everyone for coming along.
Thanks for having me. Appreciate it.
Andy.
Great job, Randy. Thank you. Thank you, Rodney.
Thanks, Rodney.
Take care. Bye-bye.
Take care.